Dear student, I greet you. I am Dr. Gülnara Ibrahimova from Department of Pathological Physiology of Azerbaijan Medical University. I want to explain the topic Pathophysiology of digestion system. Insufficiency of digestion is such a state of the gastrointestinal tract when it doesn't ensure assimilation of the food entering in the organism. Activity of all part of the digestion system is regulated by neurohumoral mechanism. Pathology of digestion divided according to the anatomical principle. Disturbance of digestion in the oral cavity, disturbances in the processes of digestion in stomach, disturbances of digestion in intestine. The main etiological factor of the digestive system diseases are the following: alimentary factor, physical factor, physical factor, chemical factor, biological factor, social factor, congenital factor, and etc. Disturbances of appetite are the following: anorexia, appetite decreases; hyperrexia, pathologically increased appetite; pararexia, tendency to consume non-alimentary substance, choke, coal, and etc. Frequently, disturbance in digestion begin in oral cavity, disturbance of chewing, disturbance of function of salivary gland, disturbance of function dysphagia. Disturbance of chewing depend on absence or damage of teeth, disturbance of lower mandibular nervous muscular apparatus, damage of mandibular joint and mandibular bone, inflammation of oral cavity and mucous membrane of palate, damage of tongue muscle. Disorders in salivary secretion are the following: hypersalivation and hyposalivation. In the hypersalivation, increasing secretion of saliva, reason of hypersalivation, excitation of salivary gland center in medulla oblongate bulbar paralysis, irritation of receptor of mucous membrane of oral cavity, esophagus and stomach under action of food mass, inflammatory process in oral cavity, gingivitis, stomatitis, and pulpitis, irritation of parasympathetic nervous system, innervation of salivary gland system, action of some drug, toxin, vegetative poison, pilocarpine, physostigmine, and etc., and influence in endogenous and exogenous factor, and etc. Result of process: maceration of skin of lip, hyperosmolar hyperhydration, excretion of different toxic product of metabolism with saliva. In the hyposalivation, decreased secretion of saliva. Reasons of process: damage of salivary gland, obturation of lumen of salivary gland with stone or compression from outside with tumor and scar, disturbances of neurohumoral regulation of excretion of salivary gland, damage of cerebral cortex, hypothalamus and nervous plexus, innervation of the gland system, action of some vegetative poison, atropine, scopolamine, and hyperthyroidism, diabetes mellitus, hyperhydration, heavy sweating, diarrhea, and etc. Result of process: food mass doesn't mix completely with saliva, difficulty in chewing and swallowing act, dryness of mucous membrane of oral cavity, foam, Sjogren disease, on the surface of tongue and gingiva, foam plaque which consists of dead epithelial cells, favorite condition, foam for stomatitis, gingivitis, and glossitis, and etc. Disturbance of motor function of esophagus, pathological change of esophagus, impeded movement of the alimentary bolus to the stomach. There are two processes: intraesophageal and extraesophageal process. In the intraesophageal process, intraesophageal tumor, inflammation, action of different drugs, acute and chronic esophagitis, spasm of esophagus. Extraesophageal process, extraesophageal tumor, metastasis to the lung system and mediastinum, tumor and cyst of diaphragm, dilation of cardiac cavities, sclerosis process during tuberculosis in lung system, hernia, hiatal hernia, and diverticula. There are pathological of esophagus. There are two diseases, scleroderma and achalasia. In the achalasia, pathology occurs in the lower sphincter of the esophagus. In achalasia, acute disorders of nervous fever in the lower sphincter of the esophagus and decreasing activity in CNA neurons. What does it mean? NCNA, non-cholinergic, non-adrenergic nervous system disorders, sphincter pressure too high, food portion or food mass cannot pass through the esophagus expansion, food must stay a long time in the esophagus. Complication of the achalasia, there may be perforation and organism loss weight, trouble swallowing, pain, and form esophagitis after pneumonia. Other disease, scleroderma. In scleroderma, the esophagus is completely damaged. The muscle of esophagus wall replaced by fibrous tissue. Decreasing autonomy of muscle, no peristaltis in smooth muscle of esophagus, decreasing of motility of esophagus from hypomotility. After form gastroesophageal reflux. The lower sphincter remained open. The chyme returned from the stomach to the esophagus with feedback. This process is called the esophageal reflux. Reason of gastroesophageal reflux: if take acetylcholine, alpha-adrenergic agonist, hormones, protein-rich food, histamine, and increasing pressure in esophageal sphincter inhibit this reflux. If take beta-adrenergic agonist, several hormones, dopamine, NO, prostaglandin, chocolate, acid gastric juice, fat, smoking, decreasing pressure in esophageal sphincter, promoter reflux. In time, sphincter pressure decreases, saliva product decreases, abdominal peristaltis occur, and volume clearance and pH clearance decrease, form reflux esophagitis, and change normal epithelial cell, formed epithelial metaplasia, then carcinoma. In time, the lower sphincter remained open, the chyme returned from the stomach to the esophagus, and irritation and this place. Stomach have several functions: secretory function, motor function, reservoir function, excretory function, absorption function, barrier function, and protective function. I want to show the interesting slide. Slide show in normal process, absorbed from the stomach water and alcohol, from duodenum iron, calcium, fat, sugar, from jejunum sugar, proteins, from ileum bile salt, vitamin B12, from colon water and electrolyte. If disorders this process and form dangerous. As seen on the slide, various substances affect the stomach, reducing or increasing the secretion of gastric juice. Disturbance of secretory function of stomach, qualitative change and quantitative change. Quantitative change of stomach juice secretion, secretion and form two processes, hypersecretion and hyposecretion. Increasing secretion of stomach juice, this process is called hypersecretion. If decreasing secretion of stomach juice, this process is called hyposecretion. Qualitative change of stomach juice secretion and have several types: hyperacidity, hypoacidity. Is a hyperacidity increasing on stomach general acidity juice? Is a hypoacidity decreasing on stomach general acidity juice? Is a hyperchlorhydria increasing amount of free hydrogen chloride? In the hypochlorhydria decreasing amount of free hydrogen chloride? Absence of hydrogen chloride and pepsin in stomach juice. This process is called acylia. A result of gastric juice hypersecretion. Hypersecretion reasons: a lot of secretory cells, hypertrophic gastritis, hypersecretion of gastrin, vagotonic effect, effect of glucocorticoids, ascorbinic acid, form heartburns, belching, regurgitation, and constipation. In hypersecretion, the stomach, sore cream, pass into the duodenum, then a reflex spasm of pyloric sphincter of stomach. Emptying of the stomach slows down. Food must stay a long time in the stomach, absorbed or digestion disorders. Pyrosis, regurgitation, vomiting, and constipation are absorbed. In constipation, weakening peristalsis of intestine. Result of gastric juice hypersecretion. Hypersecretion reasons: acylia, absence of hydrochloric acid and enzyme in the gastric secretion, formed diarrhea, hypervitaminosis, and anemia. In hypersecretion, the hyperacidic chyme of stomach pass into the duodenum. Emptying of the stomach is accelerated. Pyloric sphincter is open. Secretion of the pancreas juice is also decreased. Insufficiency processes chyme passing in the lower part of the intestine, irritate its walls, or causes diarrhea. In the diarrhea, organism loses a lot of substance because from hypervitaminosis and anemia. Disturbances of motor function of stomach may be formed dumping syndrome, vomiting, nausea, hiccup, and burning, regurgitation, and early satiety syndrome. Cause and consequence of vomiting. Vomiting occur if activate vomiting center by several elements, maybe for example, bacterial, toxin, hypoxia, nicotine, uremia, and vomiting form in motion sickness and vestibular disease if increasing pressure intracranial, and in the pregnant, if disorders in the stomach, inflammation in the stomach, in delay heavy meal in the stomach, in the intestine obstruction, inflammation and overtension of peritoneum. After this process, activate vomiting center and absorbed vomiting. Is a vomiting warning sign, outbreak of sweat, flow of saliva, white pupils, and etc. The organism loses a lot of sodium, potassium, and hydrogen, and loss of gastric juice. If organism loss of gastric juice, decreases of blood volume, form hypovolemia. In the hypovolemia, decrease perfusion of kidney, secretion more renin, angiotensin 2, then aldosterone. Aldosterone has effect increasing excretion potassium and form hyperkalemia if organism loses sodium and decreasing of sodium in blood form hypernatremia if loss hydrogen and form alkalosis, pH increasing by compensatory increasing excretion basic element. If organism lose and just gastric juice and decreases of blood volume and then increases antidiuretic hormone and increasing excretion of water. Finally, form hypokalemia, hypernatremia, and alkalosis, non-gaseous alkalosis. Dumping syndrome occurs after gastric resection and during this operation and gastrectomy, bilirubin 1, bilirubin 2, vagotomy, the stomach is resected and or disorders function of stomach. Food mass immediately pass into duodenum. Blood sugar increases, after then decreases. Gastric volume decrease, and emptying increase. Preparation of chyme decrease, pancreatic secretion decrease, gastric secretion decrease. If gastric secretion decrease, non-form internal factor and non-absorption cobalamin and form cobalamin deficiency anemia after then iron deficiency anemia because absorption iron of disorders and form hyperglycemia, then reactive hyperglycemia and form dumping syndrome, early dumping syndrome, late dumping syndrome. Early dumping syndrome form 30 and 60 minutes after meal. Late dumping syndrome form 90 and 180 minutes after meal. Finally, form anemia, osteomalacia, and weight loss. Maybe the organism lost consciousness because immediately increasing blood sugar, then decreasing blood sugar and water secretion increases, form diarrhea, weight loss, and organism lost consciousness. Ulcer disease of stomach and duodenum. Ulcer form in the stomach and intestine. Stomach and intestine has protective and damaging property. An imbalance of this factor forms an ulcer. And protective factor, mucous factor, bicarbonate, blood flow, epithelial regeneration capacity, and prostaglandin. And damaging factor, gastric acidity, peptide enzyme. And there are injury factor, Helicobacter pylori, aspirin, cigarette, alcohol, and gastric hyperacidity. Next, ischemia, shock, delayed gastric emptying. Damage factor injured the gastric and intestine mucosa and cause ulcer. I want to repeat the protection and damage factor. Protection factor, mucous factor, bicarbonate factor, epithelial barrier, and blood perfusion. Next, danger factor, Helicobacter pylori, and secretion of gastric juice increases. Bicarbonate secretion decreases. Cell formation decrease and decrease of blood perfusion. I want to explain the slide showing the formation on the ulcer. Bile salt, aspirin, alcohol, ischemia, influence in the mucosal barrier in the stomach and intestine, and then damaged mucosal barrier, decreasing function of mucosal cell, loss of large junction between cell, and increasing acid in the stomach and intestine. After formation and liberation of histamine, histamine increases. Histamine influence in the vessel dilation, increased capillary permeability, loss of plasma protein, and form mucosal edema, loss of plasma into gastric lumen. Histamine increases, then increases acid secretion, acid stimulation of cholinergic plexus, and form muscle spasm of stomach and intestine. Conversion of pepsinogen to pepsin. Pepsin influence mucosal cell, injury of mucosal cell of stomach and intestine, destruction of blood vessel from bleeding. Then influence Helicobacter pylori, mucosal injury of stomach and intestine, finally form ulceration. Result of ulcer disease, development of scar tissue, perforation, next and bleeding after malignance, formation malignance tumor, malignance tissue. Disturbance of digestion in intestines, disturbances in the secretory function, disturbances of luminal and mucosal digestion, disturbances of absorption process, disturbances of motor function, fermentation and putrefaction process, if increasing toxic element in organism, don't passing this element and formed outer intoxication. The pancreas is also involved in the digestion system. The pancreatic duct and bile duct together enter in the duodenum. In disorders of this process, disturbs the digestion system, digestion process. There are several causes, and duct obstruction, and cell injury and defective intracellular transport. In the duct obstruction, disorders ampulla obstruction, chronic alcoholism, and ductal disorders. Influence alcohol in the cell, drug, trauma, ischemia, virus, and intracellular transfer disorders, metabolism, influence alcohol, and in each case the extra and intra enzyme are activated, form interstitial edema, impaired blood flow, form ischemia, release of intracellular and extracellular enzyme, then activate, and disorders of interstitial tissue and parenchyma, pancreas, and form edema, proteolysis, and form fat necrosis, hemorrhage, finally formed acute pancreatitis. This process cause acute pancreatitis. In time, activity all extracellular and intracellular enzyme, example, phospholipase A2, elastase, complement system, prothrombin, kallikrein, finally from hypercalcemia, hyperglycemia, pancreatic gangrena, pain and shock. If active enzyme influence in the lung system, in the kidney, maybe from hypoxemia and anuria. Disturbance of membrane digestion are called malabsorption syndrome. The following processes are absorbed: processing, luminal digestion, mucosal digestion, absorption, mucosal processing, and removal. If disorders this process and formed digestion disorders. Cause of consequence of malabsorption syndrome, reason of syndrome, disturbances structure of microvillus and decreasing their amount, maybe from hereditary disease and acquired disease. Hereditary disease, for example, Hartnup disease, Low disease, maybe and disturbances of intestinal peristaltis. This process developed during Whipple disease and Crohn disease. Malabsorption occur in the gastrectomy, gastric resection, vagotomy, chronic pancreatitis, pancreas carcinoma, gastrinoma, and several diseases, maybe and lymphangiectasia and ischemia in vasculitis and disorders of protein absorption, formed edema, weight loss, muscle fasting, and disorders of absorption carbohydrate, maybe from watery diarrhea, flatulence, and if disorders of absorption sink from decreasing testing and decreasing wound healing, disorders of absorption iron, cobalamin, and folate, formed anemia, glossitis, and etc. If disorders of absorption calcium may form tetany, and magnesium may form paresthesis. Uh, the site shows all the sign malabsorption syndrome and sign hematopoietic system and skeletal muscle system and endocrine system, of skin system and nervous system. Disturbance of motor function of intestine and have two type, and increasing of intestinal peristaltis. This process is called diarrhea. Next, weakening of intestinal peristaltics. This process is called constipation. Type of diarrhea: hyperosmolar diarrhea, hypersecretory diarrhea, and hypo and hyperkinetic diarrhea observed. Constipation, a type of constipation. What does means constipation? Constipation, stool delay in the intestine. Constipation may be caused by spasm of the lower part of the colon or atony. Have several type constipation: atonic constipation, spastic constipation, mechanic constipation, and rectal constipation. And causes constipation and obstruction, intestine obstruction. By affected these factors, it causes constipation and intestinal obstruction. In constipation and intestinal obstruction, the intestinal wall is compressed for favorable reason. Finally, digestion is impaired and causes rectal distension, contraction of the pelvis floor, food blow in bulk, intestinal volume decreases, intestinal motility decreases, and form paralysis ileum. And this process occurs in the surgery, as if influence trauma, peritonitis, mechanical factor, and the stool doesn't pass through the intestine and delay in the intestine, and increasing accumulation bacteria in the intestine by asthenic and dystenic way. Bacteria secretion more toxic element enter in the vessel, in the blood, and circulation in the body, form auto intoxication, change normal structure wall of intestine, form inflammation, ischemia, wall edema of intestine, finally form vomiting, hypervolemia. Why? Because secretion increases and absorption decreases, and form pain. If delay stool in the intestine, form megacolon. Megacolon occur in the diseases which is called Kirschburg disease. Kirschburg disease is a hereditary disease observed in the child organism. Intestinal obstruction have two form, mechanical form and dynamic form, and two mechanical form have two type, obturation type and strangulation type. Dynamic form and has spastic form and a paralytic form. Intestinal obstruction, impaired intestinal function, and the stool doesn't pass through the intestine, and disorders absorption, and disorders digestion. Type of intestinal obstruction: herniation, adhesion, interception, and volvulus.
As you know, the liver is the main organ of metabolism. First, let's revise the main functions of the liver. We say liver is a biochemical laboratory of our body, and the slides show you its main functions. The first is the regulation of the carbohydrate metabolism, protein synthesis, vitamin metabolism, participation in the lipid metabolism, biosynthesis and biosecretion, then participation in the mineral metabolism, the hemacoagulation, then immune barrier, antitoxic functions of the liver, and the participation in the hormonal balance, the hormonal metabolism. Also, acid-alkaline balance is regulated by liver. The regulation of all these processes, liver ensures the normal hemostasis of the body. That's why the stage when liver cannot provide the hemostasis of organism is called hepatic insufficiency. Or in other words, we can say hepatic insufficiency is a condition in which the functional activity of the liver cannot provide hemostasis. The reasons of liver pathology. Various agents may damage the hepatic tissue and cause diseases of the liver. We may divide them in two groups, infectious and non-infectious factors. Infection factors are, number one, it's viruses, hepatotropic virus A, B, C, D, E, you know, and there are the viruses that especially damage the liver, and non-hepatotropic viruses, for example, Epstein-Barr viruses, cytomegaloviruses, yellow fever viruses. These viruses damage all organisms as well as the liver. And then the pathogenic bacteria, for example, leptospirosis, Toxoplasmosis gondii, spirocheta, then it may be fungi and parasites, for example, echinococcus, alcohol poisoning, industrial poisoning, especially carbotetrachloride, combinations of the phosphorus compounds, the lead, mercury, and others, plant poisons, aflatoxin, mushroom poisons, the toxic metabolites in the organism, some drugs, for example, the paracetamol, barbiturates, sulfanylamines, antibiotics, and especially rifampicin is very dangerous for liver, for the hepatic tissue, and ischemic injury of liver, autoimmune injury of liver, and some the genetic diseases, for example, hemochromatosis, Wilson diseases. There are genetic diseases of the liver. For example, hemochromatosis associated with iron overload. It occurs during thalassemia. Wilson disease characterized by excess copper storage in the liver, in the brain cells, and the main feature of these diseases, Kaiser-Fletcher rings in eyes, are seen in these diseases. And pathogenic agents may enter the liver by different ways. By parenteral way, for example, during blood transfusion, injection of the various substances, hemodialysis, then it may occur during transplacental way, and enteral way, for example, oral fecal way. Now the slides show us cirrhosis, but previously in brief about the hepatitis. Acute and chronic diseases of liver are distinguished, and hepatitis is a diffuse inflammatory disease of liver. This may be primarily and secondarily. And depending on the course, it may be acute and chronic. In patients with activity of transaminases, ALT, AST, alkaline phosphatase, and GGT, gamma-glutamine transpeptidase, increase in all types of the hepatitis, as well as the concentration of free and conjugated bilirubin increase too. And the ALT and AST, alkaline phosphatase and gamma-glutamine transpeptidase are not specific for liver injury. They increase during most types of the tissue injury. But increasing of the ALT more characteristic for liver damage. But in alcoholic hepatitis, we observe domination of the AST, increasing of the AST. The increasing of the GGT, gamma-glutamyl transpeptidase, and alkaline phosphatase relate to cholestasis, cholestatic liver pathology. Now about the cirrhosis. Liver cirrhosis is a chronic progressive disease characterized by gradual replacement of the liver parenchyma with connective tissue, fibrosis, and a decrease in a number of hepatites. Post-necrotic, you see here, portal and biliary and even mixed types of cirrhosis are known. Cirrhosis is accompanied by jaundice, itching of the skin, general weakness, fatigue, then hemorrhagic syndrome and other syndromes. Complications of the cirrhosis include liver failure, liver hepatic insufficiency, portal hypertension, and hepatocellular carcinoma. In all types of cirrhosis in the liver, chronic cellular dystrophy is observed, and elements of connective tissue develop. This results in decrease in the parenchymal elements of liver, and they are replaced by fibrosis. Gradually, this change causes hepatic insufficiency. Liver has the marked regenerative capacity and a large functional reserve. Hepatic failure may develop from severe acute and fulminant liver injury with massive necrosis of liver cell, acute hepatic failure, or from advanced chronic liver diseases, chronic hepatic failure. Hepatic insufficiency is a condition in which the functional activity of liver cannot provide hemostasis. And depending on the cause of the damage of the hepatocytes, hepatocellular, you see here, cholestatic and hepatavascular forms of insufficiency are known. But according to the course, fulminant, acute, and chronic forms, and according to the degree of lesion of the hepatocytes, are reversible and irreversible forms are known. Hepatocellular insufficiency develops as a result of direct action of pathogenic factors, for example, viruses, hepatotropic poisons, ionizing radiation rays, and others, on hepatocytes. Hepatocellular insufficiency develops in hepatitis, fatty hepatosis, the Rhea syndrome. This syndrome develops in children under 4 years old age when taking aspirin against acute viral infection, and is characterized by fatty infiltration of liver, cerebral edema, and the hepatic insufficiency also may lead to the liver abscesses, liver cirrhosis. Cholestatic failure. This form develops in disturbance of the formation of secretion bile. One of the main reasons for its development is obstructive jaundice. Long-term cholestasis damage to hepatocytes is associated with the mechanical and toxic effects of bile on hepatocytes. Hepatavascular form of insufficiency develops as a result of circulatory failure of the liver and occurs with portal failure, liver ischemia, and etc. Hepatic failure can be complicated by hepatic encephalopathy, hepatic coma, hepatorenal syndrome, and other pathologies. Hepatorenal syndrome is a functional pathology of the kidneys which occurs as a result of compression of the kidneys and the renal artery with acidic fluid accumulates in the abdominal cavity. Hepatorenal syndrome is characterized by progressive azotemia and increase in creatinine and oliguria. Hepatic encephalopathy or hepatocerebral syndrome occurs as a result of action of toxic substances as ammonia, phenol, and etc. on the central nervous system. Hepatocerebral syndrome is characterized by disorders of consciousness, the motor function of the central nervous system, for example, tremor, ataxia, muscle rigidity, and also may lead to the hepatic coma. Hepatic insufficiency manifests itself in disturbances of barrier function of liver and change in all types of metabolism, and primarily in change in the carbohydrate metabolism. Damage to hepatic cells cause disturbances in the synthesis and breakdown of the glycogen. So in hepatic insufficiency, regulation of the blood sugar is disturbed and hypoglycemia occurs easily. Decreased synthesis of proteins leads to the hypoalbuminemia and paraproteinemia. Blood content of free amino acids and residual nitrogen is increased. Ammonia is accumulated in the organism which cannot be detoxified by the liver. Synthesis of urea in the damaged hepatic cells is disturbed. Blood content of uric acid is also decreased. In severe lesions of the liver, its detoxification function is disturbed, organism sensibility to the toxic substances and drugs is increased. And in the diseases that are accompanied by damage to the hepatic parenchyma, for example, in acute viral hepatitis, intoxication by hepatotropic poisons during cirrhosis, the large amount of the under-oxidized metabolites, ammonia, and vital activity of metabolites of intestinal bacteria are accumulated in the organism, and they disturb the function of the central nervous system, and in severe cases they may cause hepatic coma. Now the types of the hepatic coma. The hepatic coma is characterized by loss of consciousness and occurrence of neuropsychiatric disorders. disruption of the body's vital activity. The hepatocellular and hepatic shunt coma, even the mixed type of this coma, are distinguished. Hepatic shunt coma develops as an outcome of the hepatic cirrhosis and accompanied with increasing pressure in portal vein. Result in develop the portal cable anastomosis and part of blood containing toxic products without passage into the liver enter into the general blood circulation. The another form, hepatocellular coma. Hepatocellular coma develops on the background of massive necrosis of the liver parenchyma. In this case, all functions of the liver are disturbed. And it results in a large number of the ammonia here. The ammonia doesn't neutralize in the organism and general intoxication of the organism occurs. And this is called cerebrotoxic effect. In mixed form, hepatic parenchyma is damaged and also pressure in portal vein increases. Portal hypertension develops in about 30–60% of patients with cirrhosis. Portal hypertension is a large complex of changes connected with increased pressure in the portal system and usually follows obstruction of the portal blood flow anywhere along its course. The normal portal venous pressure is quite low, 10–15 mm silent. Portal hypertension occurs when the portal pressure is above 30 mm hydraulic. And four types of the portal hypertension are distinguished: prehepatic portal hypertension, intrahepatic portal hypertension, you see here, the posthepatic portal hypertension and its mixed form. Prehepatic portal hypertension the results from blockage of portal flow before portal blood reach the hepatic sinusoids. Intrahepatic portal hypertension occurs in cirrhosis. There is obstruction to the portal venous flow by fibrosis, thrombosis, and pressure by regenerative nodules. Posthepatic portal hypertension it is uncommon and results from obstruction of the blood flow through hepatic vein into the vena cava inferior. It occurs, for example, it may observe during neoplastic occlusions, thrombosis of the hepatic vein, or in the thrombosis of the vena cava inferior. And mixed form of the portal hypertension. Portal hypertension also has an effect on general hemodynamics. Most of the circulating blood here accumulates in the abdominal organs. This leads to the hypovolemia, tachycardia, a decrease in systolic and cardiac output, and a decrease in blood pressure. As the supply tissue with oxygen is disrupted. The effect on the vessels of the vasodilators synthesized in the body during hypoxia leads to the even greater decrease in blood pressure. And the explanation of the expansion of the capillaries leads to the hyperperfusion of the abdominal organs, which deepens the development of the ascites. In the pathogenesis of the portal hypertension, there are four major clinical consequences observed. The first you see here in this slide, the ascites, varices, splenomegaly, hepatic encephalopathy. Ascites is the accumulation of the free fluid in the abdominal cavity, and formation of the ascites associated with the following changes in the organism. The first is increased pressure in the portal vein and vascular permeability. An increase in hydrostatic pressure in the portal vein, and the filtration of the vessel of the abdominal organs is accelerated here. Then the second, decrease in the plasma-oncotic pressure may lead to the formation of the ascites. Hypoproteinemia and especially hypoalbuminemia resulting from the decrease in the synthesis of albumin in the liver, And this leads to the decrease in the oncotic pressure of the blood. And this leads to the transudation of the fluid from the vessels to the abdominal cavity. The next reason is secondary hyperaldosteronism. Impaired liver can't metabolize the aldosterone, and its concentration in the blood increases. Decrease in the circulating blood volume also leads to the activation of the renin, angiotensin, aldosterone system. And aldosterone accelerates the reabsorption of sodium and water in the distal convoluted tubules of the kidneys. Hypersecretion of the vasopressin takes the main role in the formation of the ascites stool. Hypernatremia resulting from secondary hyperaldosteronism cause an increase in osmotic pressure and irritation of the osmoreceptors. As a result, the secretion of ADH vasopressin increases. Hypersecretion of the vasopressin is also associated with hypovolemia. And at last, you see here splenomegaly is increasing the size of the spleen, develops as a result of stagnation of blood in the spleen, the delay of the circulating blood in the spleen, and the destruction of the blood cells in the sinusoids of the spleen. All this leads to the leukopenia, anemia, and thrombocytopenia. An important manifestation of impaired bile production and bile secretion is jaundice. To understand the mechanism of biliary pathology, it's important to understand normal bilirubin metabolism. As you know, bilirubin is derived from the catabolism of hemoglobin, of senescent erythrocytes, red blood cells, which are distracted, at the end of their normal life, which is their lifespan is 120 days. They distracted in the reticular endothelial system, in the bone marrow, spleen, and liver. Here, heme is converted into the bilirubin earlier, and then into the bilirubin. Bilirubin circulated as in the form of the unconjugated. Also, this is called free bilirubin or the indirect bilirubin. Indirect bilirubin in plasma tightly bound to albumin. Bilirubin is found in the body fluids in proportion to their albumin content. And in the hepatocyte surface, free bilirubin, this is unconjugated bilirubin, is involved to three important processes. The first is hepatic uptake, then conjugation, and then secretion into the bile. Free bilirubin is not water soluble, but is alcohol soluble and is converted into the water soluble compound by conjugation, after conjugation. Conjugation occurs by the action of the enzyme, this enzyme called glucuronil transferase. And the process of the conjugation may be induced by drugs like phenobarbital. Conjugated bilirubin secretes to the duodenum with bile, and in intestine, bilirubin is separated from the glucuronic acid, reduced and converted into the urobilinogen. The main part of the urobilinogen passes into the large intestine, is reduced by the participation of the anaerobic microflora and converted into the stercobilinogen. A small part of the urobilinogen is absorbed from the intestine, returns to the liver by portal veins, and breaks down here, excreted from the body with bile. But a very slight, small amount of the urobilinogen escape from here past general circulation. And that's why urobilinogen we detect in the urine even in normal state. And disappearing of the urobilinogen indicate about obstruction of the bile secretion into the duodenum. For example, it may occur during the mechanical jaundice. And increasing of the urobilinogen in urine is a result of damage of the liver parenchyma, hepatic parenchyma. In the lower parts of the large intestine, stercobilinogen is oxidized, stercobilin is formed, which is excreted in the stool and imparts to it normal brown color. Free bilirubin doesn't pass into the urine. Conjugated bilirubin is excreted in urine and is almost absent in blood. Normal blood serum contains approximately 0.2 1.2 milligram d-liter of the total bilirubin, and out of which less than 0.25 milligram is the conjugated bilirubin. Increased content of the conjugated bilirubin in the blood serum is a pathological symptom, and that's observed in the jaundice, about which we will talk in the next slides. Posthepatic, prehepatic, and intrahepatic. And skin is colored in the lemon yellow color in the hemolytic jaundice, that's prehepatic jaundice. Saffron yellow in the parenchymal jaundice, intrahepatic jaundice, and in olive green, where intensive green color in the mechanical or posthepatic jaundice. And jaundice icterus is a pathological condition characterized by yellow pigmentation of skin, mucous membranes, and sclera, as well as the blood serum, due to the deposition of the bilirubin here. Jaundice may be accompanied also by accumulation of bile acids and other bile components in the blood, this state called cholemia. Jaundice becomes clinically evident when the total serum bilirubin exceeds 2 mg dl. Jaundice may result from one or more of the following mechanisms. The first is increased bilirubin production. The second, decreased hepatic uptake. Then decreased hepatic conjugation. And at last, decreased excretion of the bile, bilirubin into the bile. All they may result into the jaundice. Now here in detail about the pathogenesis of the types of the jaundice. We say three types of the jaundice are known. The first, prehepatic or hemolytic jaundice, due to intensive breakdown of the blood erythrocytes and increased bile production. The second type, intrahepatic or parenchymal or retention jaundice, it occurs due to impaired function of hepatic parenchyma. And the third type of the jaundice, posthepatic or cholestatic, or we call this mechanical jaundice, occurs due to impaired bile secretion caused by mechanical obstruction in the extrahepatic bile ducts. About the hemolytic jaundice, prehepatic jaundice may be caused by all factors that result in the hemolytic anemia. The hemoglobin liberated in hemolysis is transformed into the free bilirubin, which forms so large an amount that the liver fails to excrete it. Since free bilirubin is not excreted by kidney, in hemolytic jaundice there is no bilirubin in urine, but its large amount passes into the intestine. This leads to increased excretion in feces, and the stool here, that's why, is dark brown. Unlike the other forms of jaundice, the cases of the hemolytic jaundice are not accompanied by retention of the bile acids and cholesterol in the blood. Some types of jaundice in the newborn belong to this, the jaundice of the newborn belong to this group of the jaundice. The parenchymal jaundice or intrahepatic, this connected with separate or combined disturbance of hepatic uptake, conjugation and secretion of the bilirubin into bile. There are hepatocellular, enzymatic and cholestatic forms of parenchymal jaundice. In hepatocellular jaundice, hepatocytes undergo pathological processes. Depending on the level of the damage to hepatocytes, cholemia, fermentemia, progressive liver failure, and coma, even coma can develop. Jaundice accompanied by damage to hepatocytes, and that's why the activity of the enzymes ALT, AST, the GGT, and other enzymes increases. Enzymopathic jaundice can be primarily or hereditary and secondarily acquired form. Primarily, enzymopathy occurs in genetic deficiency of enzymes involved in the metabolism of bilirubin and proteins that play a role in pigment metabolism in the liver. Primary enzymopathies include Gilbert syndrome, Crigler-Najjar syndrome, Darwin-Johnson, and Rotor syndrome. Gilbert syndrome. It is a hereditary disease that transmitted by autosomal dominant pathway of the inheritance. At its beginning it's benign and is a relatively common form of jaundice. In these patients, there is a deficiency of the enzyme glucuronidase transferase, and the hepatic uptake of bilirubin by hepatocytes is also impaired. In patients, there is an increase in the content of unconjugated bilirubin here. It's not more than 3-6 mg DL. Moreover, liver damage and erythrocyte hemolysis are not observed. The disease is familial and accompanied by yellowing of the sclera. Jaundice is intermittent, and after use of the phenobarbital for therapeutic purpose, a relative normalization of the level of the bilirubin is observed. The second type is the Crigler-Najjar syndrome. Two types of Crigler-Najjar syndrome are distinguished. The first type has a more severe course and is characterized by a complete deficiency of this enzyme, glucuronidase transferase. And the second type is characterized by partial deficiency of this enzyme. The basis of pathogenesis of these diseases is disturbance of a conjugation of bilirubin. Type 1 Crigler-Najjar syndrome is rare. In this case, the level of conjugated bilirubin is higher than 20 mg DL. Functional liver tests are within normal limits and bile is discolored. Phenobarbital treatment is not effective. Type 1 Crigler-Najjar syndrome can be complicated by bilirubin encephalopathy, nuclear jaundice. So, without albumin, unconjugated bilirubin crosses the blood-brain barrier and cause damage to the brain tissue. This leads to the hepatic encephalopathy. The occurrence of severe neurological signs leads to the death in the first year of the patient's life. In type 2, in the second type of Crigler-Najjar syndrome, the level of unconjugated bilirubin is lower than 20 mg DL and this disease has a benign course. Treatment with phenobarbital gives a temporary effect. Darwin-Johnson and Rotor syndromes arise as a result of genetic defects in the transport protein that ensures the transition of the conjugated bilirubin from hepatocyte to the bile ducts. Both syndromes are inherited by autosomal recessive way. Darwin-Johnson syndrome is accompanied by transient intermittent jaundice. In patients, the level of conjugated bilirubin rises, the color of the liver becomes dark. Hepatomegaly develops and pigment granulars are detected during biopsy. Because here not only genetic defect in the transport protein that ensures the transition of the conjugated bilirubin from hepatocyte to the bile ducts, but also here the genetic defect in melanin synthesis and secretion is observed too. Rotor syndrome is similar to Darwin-Johnson syndrome. The level of conjugated bilirubin is lower than 10 mg DL, but pigment particles are not detected during liver biopsy. Since the parenchymal jaundice, the blood contains bile acids, all signs of cholemia, itching, bradycardia, and decreasing of the arterial pressure are observed. And mechanical, the third type, or posthepatic jaundice, or the cholestatic jaundice, results from the mechanical obstruction to large bile ducts outside the liver or within the portal hepatis. The common causes are gallstones, inflammation, carcinoma of the head of pancreas, tumors of the bile duct, congenital atresia of the extrahepatic ducts. Above the obstruction, the bile ducts are distended by bile, and bile is absorbed into the lymphatic system, gain entrance to the general circulation through the thoracic duct, and all this results in general intoxication. Hyperbilirubinemia, both free and conjugated. Bilirubinuria, excretion of the bilirubin by urine, are observed, but urobilinogen in urine and stercobilin in feces are decreased. When the biliary tracts are completely obstructed, bile cannot enter the intestine. This is called acolia, and the stool of such patients become clay-colored. The general change in the organism caused by the passage of the bile into the blood are called syndrome of the cholemia. The signs of this syndrome, cholemia syndrome, are bradycardia and decreased arterial pressure, then itching, intensive itching, and the headache, temporary excitation, but then depression of the activity of central nervous system. And here in brief about the cholelithiasis. Cholelithiasis is characterized by formation of stones, gallstones in the gallbladder and bile ducts. The main cause of the cholelithiasis are following. The first, the reasons of the cholelithiasis are disturbances in the metabolism, metabolic change. The increased content of cholesterol and bile pigments in the bile may lead to the formation of the gallstones. Then stagnation of the bile, and the last is infection and the inflammatory process in the gallbladder. The incidence of gallstones varies markedly in different geographic areas, genetic factors, age, sex, diet, and other risk factors. Gallstones are formed from cholesterol, bile pigments, calcium salts, and other organic compounds. 80% of the stones are cholesterol stones, and the remaining stones are pigment stones consisting of calcium salts or bilirubin. And again, this slide shows us gallstones removed from real patients. The gallstones are of the three major types: cholesterol gallstones, pigment or calcium carbonate gallstones, and mixed gallstones. And at the end, I would like to explain you how we investigate the hepatic functions in experiment. In the pathological conditions, a number of methods are applied, and you see here egg fistula and Pavlov's egg fistula. And the barrier function, protective function of the liver is demonstrated by the help of the egg fistula. That's anastomosing of the portal vein to the vena cava inferior, which ensures the free flow of the blood from the former to the latter. Above the anastomosis, the portal vein is ligated, whereby the liver is excluded, removed from the vascular system of the digestive organ. So the substances passing into the portal vein from the intestines bypass the liver, enter to the vena cava, and then the general circulation, general blood flow. And 12 days after this operation, the animals show periodical motor disorders, rigidity of the limbs, tonic and clonic spasms. If fed this animal raw meat, the animal shows all these symptoms of the intoxication already in 3-4 days after the operation, and soon dies. The next experiment, egg reverse or Pavlov egg fistula, consists in anastomosing of the inferior vena cava to the portal vein and subsequent ligation of the vena cava inferior above the anastomosis. So blood is directed from the inferior vena cava to the portal vein. And the third operation, the operation for complete removal of the liver in dogs, is performed in 2 stages. The first stage consists in anastomosing of the vena cava to the portal vein and then ligation of the vena cava above the anastomosis. So all blood of the body and intestine is directed into the portal vein and the liver. The second stage is performed 4-5 weeks after development of powerful collaterals, which ensures the outflow of the part of the venous blood by passing the liver into the vena cava superior. Portal vein is ligated above the anastomosis and the liver is removed from the organism, from the body. After the operation, the blood sugar sharply decreases, and within 3-8 hours, symptoms of hypoglycemia they appear, and increasing muscular weakness, convulsions, hypothermia, death from hypoglycemic coma occur. After injection of the glucose, the animal may survive, but only for 20-40 hours. Hepatectomy, removing of the liver, caused increase in the content of ammonia, amino acids, free bilirubin, and decrease in the amount of urea. The toxic substances are not decontaminated and cause severe intoxication in the organism. Chain stops respiration, arterial hypertension, tachycardia, and at last coma may occur. And all this leads to the death of animals. Thank you for listening.